Join Mingle Health on our quest to improve healthcare delivery. We'll explore the transition to value-based care from the perspective of clinicians, leaders, and even patients who make up our healthcare system. I'm your host, Charles Howes, Head of Marketing here at Mingle Health. Thank you for joining us. Let's get started. Today, I'm joined by my colleague, Jason Shucker, Senior Healthcare Informatics Analyst here at Mingle Health. He's a pharmacist with a knack for data. His passion for healthcare and improving patient outcomes guides him in helping our most complex customers understand their data and close clinical care gaps. He serves as an expert to our team and customers on the intersection of data, clinical guidelines, and technology. Welcome, Jason.
Thank you, Charles. It's nice to be here today.
So before we get started and dive in here, just by way of introduction, you began your career as a board-certified pharmacist. How did you find your way to Mingle Health?
Yeah, well, I spent 10 years working as a pharmacist in a variety of different settings, and I found that I was running out of challenges, that my daily routine was very routine, and I didn't feel like I was growing as a person. I had always had a passion for data and for technology, and I happened to be introduced to Dr. Mingle, who at the time was looking for clinicians to translate clinical data for our clients.
All right, so a theme here of meeting more challenges and connecting with Dr. Mingle, who has recruited so many folks to our work here at the organization. Outside of your background per se, what's something about you that we wouldn't learn from your LinkedIn profile that you'd be willing to share with us?
Well, I think probably my kids would tell you that I tell really bad dad jokes. And I think the other thing is I really enjoy rock climbing when I am not working. I find it a great stress reliever.
Awesome. Have you been able to get out this summer?
Not nearly as much as I wanted to because it was raining so much in July, but hopefully this fall we'll take some trips to do some climbing.
We'll give a special prize for someone who spots the dad joke that emerges throughout our conversation here today. All right, diving into the topic, we often talk about unlocking your data. Let's start with why. Why are organizations spending so much time analyzing their data and working with companies like Mingle Health?
Yeah, I think the first is obviously that they have to do it for reporting programs. And there are a certain number who really are just looking to check that box. But then there's the ones that I typically get to work with are those who really care deeply about quality. And the old saying goes, a motto that they have, which is that you can't improve what you don't measure.
In terms of your work with our customers, how long does it take to trust the data that you see when you calculate performance and are looking at a performance report with a particular customer?
It really depends on the customer and the structure of their data. I think we work with some customers where their data is well structured and it's easy to read and there's no free text and everything's in its right column. And generally it's relatively straightforward with those folks. It's relatively easy to troubleshoot any issue. But there are often times where clients do have free text fields that we're mining for data. And so some of it can take a little while. But I think regardless of what your data looks like, there's always a process where we import your data, we translate your data, we give you performance, we talk with you about that performance. Does this number look correct? Does it look wrong? If it looks wrong, let's take a look at some of the patients and we can say, all right, here are 10 patients that we say are not met for this measure. Can you go through and tell me, whether or not you agree with that? Or here are 10 patients who are met. Do you agree with that assessment? And they're able to come back and say, no, I think we sent you data for this. And we go looking through and we say, yep, all right, we found that. That fixing that one data point applies to 100 patients across your 1,000 that are eligible for the measure. And so there's always a back and forth between my team and the client and just making sure that we're translating your data correctly, that we're not missing data points, or that you're not sending us data. And that's another thing that we uncover is a client might think that they have sent us, this certain subset of medications and it wasn't in their medications file. So we end up, going back and forth, figuring that out. They upload that extra medications file and, we improve performance there. So I think it really depends on the client, their understanding of their own data, the structure of their data, but there is always a back and forth regardless, trying to get to that level of understanding. And the beautiful thing is once you get to that level of understanding and the client knows what they need to send us, and we've already done the work to translate everything, things become much faster. So it's upload the files, process it, get performance. And we don't need to do that back and forth forever.
But it's clearly a project and a collaboration, diving into these different sources.
Yeah, absolutely.
And you talked about sort of a back and forth and your day-to-day work with several of our customers, large healthcare organizations. What does it look like to make sense of their data across data sources? What are common data sources you're working with? If you could talk a little bit about what that looks like, how many practices they have, the systems that they're working with. Give us a picture of some of the work that you're doing.
Sure. Well, I think with every single client, the first thing that we start with is billing data. And so we get that from a variety of different sources. Some clients get us flat file extracts directly out of their billing systems. Oftentimes we're working with 837 files that are generated by their billing companies and provided to us. And then from there, once we've done that, and we can have a client who has multiple different systems. So one of their practices might be providing us with a flat file extract. One of them might be providing us with an 837. And we're able to consume that data, get it into our system, create a unique set of patients across those practices and use that to identify who's eligible for measures. And once we get to clinical data, we have a couple of different file types. We have QDRAs, which contain patient-level medical data in them. And we also have clinical flat file extracts, which clients are able to get out of their EHRs. For some of our smaller practices, we provide our clients with performance spreadsheets if they are still on paper charts and need to do manual abstractions themselves. And we are able to take all of those different data sources and combine them to get to the quality scores that we're able to provide for the clients.
So the common file types, we've got billing files, 837 files, QDRA. Can you talk to me a little bit about why can't you just use one file type? Why are we, if you can get the claims data through the billing system, why do you also need the other data types, like clinical data?
So I think the challenge is claims you really need to be set up. Your billing company needs to be set up, or whoever's doing your claims really needs to be confident that they understand the measures, that they are correctly applying those claims codes, that they're consistently applying those claims codes. For most clients, that's challenging. And what we find is that even when they think they're doing it 100% of the time for 100% of the patients who are eligible for the measures, they're really not, and they're missing patients. And so being able to combine those claims codes with clinical data or with a performance spreadsheet, which is a manual abstraction from their chart, being able to combine those data sources allows us to get closer to what the client's true performance is, and also helps them in the regulatory reporting programs that they have to be a part of.
Can you give me an example of a common measure and what it might mean if the performance is low, and how you've worked with a customer to improve that performance?
Yeah, absolutely. One of the most common measures that clients report would be measure 1, which is A1C control for diabetics. This measure, there's a couple of different ways that you can fail to meet the requirements. The patient could either have an A1C that is greater than 9, or you may not have done an A1C. And so one of the things that we work with clients on one is identifying where is that gap. Is it that the patient's A1C is poorly controlled, or is it that you haven't even measured the patient's A1C? And so being able to identify those patients where the A1C hasn't been done, so that next time the patient is in the office, they can write an order for that to bring up performance there. Or if you're focusing on those patients who have certain A1Cs greater than a certain level, being able to identify those patients for a client can really help improve their performance.
Wow. A lot of moving parts there just for one of our most common measures. What does the back and forth look like, or the collaboration with the customer, to understand if they just haven't done an A1C, or if perhaps there's data that's missing and you need to layer that in to improve the performance?
Well, I think one of the challenges that we face is when we do have clients who have multiple EHR, or they might have one practice which has an EHR and another is still on paper charts, or has very limited access to the data that's in their EMR. Being able to take clinical data, whether that is from a QDRA or whether that's a flat file extract, use that data to fill in the performance where we can, and then being able to take our performance spreadsheets and provide those to the clients so that they can go back and fill in the data for those patients where we don't have any access to any clinical data for them.
Sounds complicated. For our customers that you work with multiple EHRs, how come the EHR can't just output a file and we bring it together really simply in our system? What are some of the common challenges associated with that process?
Yeah, absolutely. Well, it depends on the size of the practice and the capabilities of the practice. Oftentimes, practices don't have someone on site or payroll that has ability to write those custom queries to get the data out in a useful way. Some EMRs have great built-in reports that you can use, and we certainly use those, but oftentimes the data that's generated by those built-in canned reports is not useful, or is not designed in a way that's useful for our processing and reporting performance. So the challenge when you don't own your own data, when it's stored elsewhere, when you don't have the ability to get into that data, oftentimes clients will have to work with their EMR, and it might be a fee to get certain data out. So why can't they just do this directly out of their system? Well, one of the challenges that folks have, even when they have a certified EHR system, is when using a ECQM or data directly out of their EHR for reporting, the ECQMs are designed and coded very specifically. Their system has to be certified to report the measures, and they have to follow very distinct workflows for inputting data into their system. And oftentimes, what we find is clients will want to report a ECQM with us, and when they actually look at the data and the performance in there, it's just not that good. And what they find is that they're not checking the right box. They're not putting the lab in under the right LOINC code to be captured correctly. And so one of the great things about what we do is our process is a little less prescriptive, in that if you have data that's in your system that doesn't have a LOINC code for that A1C, as long as we can identify that it's an A1C, it's a lab, and it has a value, we can use that. We are able to put together, obviously we've talked about using different sources. ECQMs and reporting directly out of your EHR, you're not able to do that. Again, you have to follow a very specific workflow. And if all your clinicians are not following that, you're not going to be getting the credit that you deserve.
Now talk to me, workflow. Break that down for me. What does that look like if I'm an end user or a clinician? What does that look like?
So for instance, one of the clients that I worked with was reporting the mammography measure, and they felt very confident when they started the process that they looked at these and they did these for all of the patients that were eligible, and they had data stored in their system. And we got our ECQMs, and we said, well, your performance just doesn't look very good. And we tried getting, which again is the actual patient level data that's coming out of their systems for those ECQMs. And we said, we're just not seeing the mammograms that you think you're doing. And so we got on a call with the client and we looked at their system and we could see, yep, this patient had a mammogram, it was reviewed, and we're not seeing that data. And so we ended up getting on a call with the client's EHR vendor and found out that when they clicked the box that they thought was going to be capturing it, that box was actually generating a SNOMED code, which was not in the prescribed list of SNOMED codes for that measure. And so the client wasn't getting any credit for that. And so we ended up ignoring the ECQMs, getting a custom output of the records that they did have, and the client ended up having really good performance.
Wow. Talk about a treasure hunt there. Are there any other reasons why we aren't able to just bring together QRDA files?
We've had a lot of questions from clients about who are under 110 but have multiple EHRs, and about whether we could combine their 3 files and say, all right, you have 10 patients in this QRDA 3 over here, and you have 10 patients over here. Let's just put this together, and our denominator is 20. And unfortunately, it's just not the way it works. Again, if we go back to measure 1, the diabetes measure, it's a once per performance period measure, meaning that a patient should only show up once in your denominator. But if you have a patient who was seen in both of those practices and they billed for an encounter that included diabetes, a diabetes diagnosis code, that patient would show up in each of those QRDAs. And so the problem there is you can't just add those numbers together, because there's a great possibility that you're going to have patient crossover and you would be misreporting your data. And CMS just actually published a fact sheet clarifying that you are definitely not allowed to combine QRDAs for exactly that reason.
You really need those advanced capabilities to bring the data together from multiple electronic health records.
Correct.
To be able to really see an accurate picture of the performance.
Yes.
And you talked about sort of a back and forth. Who are you regularly working with at some of the organizations? What's their role across the health system?
Yeah. So again, it varies depending on the organization. There are some times where I'm dealing with a single project manager who is sort of the point person to the organization's IS team, to the quality team, to various other teams. But I work directly with that singular person. And then there are other organizations where I'm working with everyone from the chief quality officer down to a project manager, down to a couple of people from the IS team. If people have data warehouse, sometimes they bring in the data warehouse folks. So it really depends on what the structure is at that organization and who they feel they need to have in those calls.
Wow. So it's a full team effort. Is there any role that if you are designing an organization that you would encourage folks to think about making sure they have or adding as we look to some of the goals that folks are trying to accomplish?
Was this one of the questions?
No.
I think that these are unicorns, but I think that it is incredibly helpful when you have a clinician who also understands data. And I think some of the challenges that organizations face is they have the clinicians who understand how things are supposed to be done, or they understand, what has to be done from a patient care perspective. And then there are those people who are IT, understand from a back end perspective what that looks like. And oftentimes the challenge is getting those two sets of folks to agree or to come to understanding. And so I think the clients who do really well have someone, whether it's a nurse informaticist, pharmacist informaticist, a physician who really understands not just the care requirements, but also the data requirements and what happens with that data in the EMR.
Wow. So unicorn. Do you have any advice for any clinicians out there who are looking to understand data more, or to really be more effective in their work based on what you just recommended?
I think the key to clinicians, I was gonna say get down in the weeds, but here's the other thing that's is just challenging for them, is that so often they don't own or store their own data. And so getting into the back end and seeing that when you click this button, this data point is generated is just really challenging for them.
Yeah. Picking up on what you just said, it sounds as if you're saying clinicians need to advocate for data and analytics around the key things that they're working on from a patient care perspective, so that they can, when they're working with the patients or working with the clinical teams, they have the data right there accessible that matches their workflow or their specialty, or, they have the data point that they can use to bring into that conversation.
Well, here's the thing. I know from my wife's work at Maine Med that they have their KPIs. They have their boards of these are the metrics that we're looking at internally. And so for larger organizations, I think they certainly have those KPIs. They have those metrics that they are looking at. And I think I don't know whether the clinicians who are looking at that actually understand the data, or they're just looking at the raw numbers. We did this many of X out of this many events. But part of, if you really want to get down into the weeds of it, understanding that data, how did you get to that number that's on your KPI board? And maybe that's, spending some time with your IS team and your data teams, and, how are they actually capturing this, and does it match what you are doing as a clinician in your day-to-day practice?
So back to that idea of what gets measured gets improved,
Correct.
And taking the time to really understand, what is this number telling me?
Yes.
And do we know how to influence it for good, or, for better or for worse?
Correct.
Yeah. No, that's great advice. Thinking about your time here at Mingle, what's an initiative or a project that you're most proud of working on with Mingle Health clients?
Yeah, so this will be my 7th reporting period or reporting year with Mingle, and I've worked with a couple of clients for all of those 7 years. And one of the things that I noticed is that many of those clients report the same measures every single year. And there's a lot of reasons why they do that. They've built out workflows. They know where the data is. We've worked through all the problems and issues with those measures. But one of the things that CMS does every year is they change the benchmarks for those measures. So a measure that you do really well, and in one year you get 8 points for that. Well, the next year, that same level of effort and same level of performance might only end up getting you 5.5 points or 6 points. And so if you look at that over, all the measures that they report, that can change that can make a big change in their total score. So knowing this, and knowing that easy or intuitive for clients to go through and see those changes in the benchmarks, I developed a report which clients are able to run at the end of making a submission for the year. And they run this report, and it tells them, all right, if you did exactly the same as you did this year, this is what your scores are going to be. And it shows them that, this measure, you're going to lose points for doing exactly the same amount of work. Do you want to spend time to increase that, or do you want to look at other measures which have the potential to earn you more points? So I think it's a really helpful tool, and something I think that clients really like looking at when they're transitioning between years.
Yeah, I've gotten to take a look at that report, and it's incredible because it has in a narrative form and a graph that shows how many visits would you have to influence to move the needle, so to speak. So it's tremendously helpful. Connecting this all back, we talk about trying to, at the end of the day, ultimately improve patient outcomes, and that all of this is for, some tangible benefit to individuals like you and I who are accessing our healthcare system. What stands out to you about quality management and in value-based care and how it actually drives value for patients?
Yeah, I think that there are organizations that I work with that take the feedback that they learn from our data gathering. And we talked about the back and forth between our when we get data and get performance. And I think they take the feedback, and oftentimes there's discussion about, well, how do we change the form in the workflow so it flags this? How do we do a better job of capturing this? Or how do we do a better job alerting our clinicians that they need to do this? I think those are all things that in my meetings with clients that I hear them say, that they're taking what they're learning from the feedback that we're giving them and applying that to their workflows so that they can better improve the outcomes for their patients. And not only that, improve the scores, which improves the incentives that they're able to receive for reporting in the programs.
Yeah, absolutely. You've said it multiple times, but that collaboration and that back and forth dialogue, looking at the data, looking at, where there's opportunities to make improvements, both from, the data source perspective, but also the care that's happening.
Absolutely.
So it's great to hear what that looks like tangibly. Any final thoughts from you that you want to share?
No, I think it's always challenging. I said that one of the reasons I left clinical practice was because I felt like I was running out of challenges in my day-to-day work. And I think some of the most rewarding stuff that I do at Mingle is that when we get a client who feels like they have data all over the place, multiple practices with multiple billing systems, multiple EHRs, and we are able to work through each of those systems, get the data we need, put together performance, and at the end of the year have that client feel like, wow, they really represented me. There's a lot of challenges along the way, but when you get to that end point, I think it's just really rewarding. I think for us as a company, as Mingle, and also for the client, when they're able to say, all right, we did this, we worked through all of this stuff. And I think that's just exciting and sort of what keeps me at Mingle.
Absolutely. Well, it's exciting to hear how we can actually be a client's true partner in this transition to value-based care, because in some ways it feels like so many that it's just another requirement.
Right.
And to really connect the dots and work together through some of the muck of this to drive value for the organization, but also for patients, and make that small step in improving our healthcare system, it's worth it.
Absolutely.
Thank you so much, Jason, for sharing your knowledge with us today. And if folks want to get in touch with you, what's the best way for them to reach out?
Probably through email.
You heard that, folks. Email. We're old school here.
Jason S. at minglehealth.com.
Well, thanks so much for sharing your wisdom today. And hopefully folks might get the chance to hear from you again, or to even work with you as a customer.
Excellent. Thank you, Charles.
Thank you for joining us. Learn more about Mingle Health and the transition to value-based care at minglehealth.com.